My name is Stephanie Elkins, and I am a hematologist and oncologist. I practice at the University of Mississippi Medical Center in Jackson, Mississippi, and I'm going to be doing the hematology and then subsequently the oncology sections of the board review. I put together this presentation to follow primarily the med study book because I think it's really well laid out. We're going to concentrate on the basics for heme and the basics for onc. We'll try not to get into too many of the esoteric zebras, but there will be a few of them there because there'll be a few of them on your board. So we'll try to hit those, try to hit the hot topics that I remember from my boards and that I've seen along the way from the residents I work with as they've taken their boards. So we'll do our best to get you prepared and ready to take this big test. Okay, well, let's get started. We've got a lot of hematology to do, a lot of ground to cover. As Tommy said, if you'll hold your questions, I'll do them at the end or at the breaks. If I do something glaringly wrong, yell at me. If I go too fast, yell at me. If you can't understand Southern, I'm sorry. It's all I know. All right, so here we go. We're off and running. We're going to start with anemia. And just a few pointers to start with. Remember that red cell production is also known as erythropoiesis, and that everything in that lineage is under the direction, ultimately, of erythropoietin. Remember that red blood cells in the in the vessels have a lifespan of about 120 days, and that when they die, their degradation is primarily through the spleen. And after they die, you see unconjugated bilirubin, and you see the hemoglobin that's produced after the red cell death transported by haptoglobin. All right, so we're going to talk about some specific anemias as we go here. Some of these are always fair game for the boards, and I can guarantee you there'll be anemia questions there. They like them. You're going to see a lot of them as a general internist. First case, 24-year-old, has fatigue and heavy menses and iron deficiency anemia. Very common problem. Which of the following labs best reflects her level of storage iron? We have choices of serum iron levels, ferritin, soluble transferrin receptor, and the percent iron saturation. All right, and I'm told y'all know what to do right here, huh? On your mark, get set, go. All right, so what'd you pick? Okay, so almost everybody picked ferritin. A few people with iron sats and a few with iron levels and soluble transferrin receptor. All right, I can buy that. And let's look at the right answer is actually ferritin to best reflect the body's stores. Okay. So let's talk just a little bit in detail about iron deficiency anemia. This is the most common anemia that you will see. And affects a great many people, all age groups, usually secondary to blood loss, can sometimes be dietary, can be malabsorption, but usually is some sort of combination of blood loss and or dietary. Remember the cardinal rule about iron deficiency anemia is you can never end with that diagnosis. It needs to be iron deficiency anemia because or from. It needs to always have a cause. You cannot just say someone's iron deficient without identifying why they are iron deficient. And remember that pregnancy is usually, almost always, an iron deficient state. Iron is taken up by the GI tract. When we eat, we take in iron, ferric iron. It's changed to ferrous iron and absorbed through the GI tract. We also have old red cells that break down, and that iron is recycled. It's transported by transferrin, and it's placed in storage form, which is ferritin. Thus, ferritin most closely equals storage iron. There are other iron measures, and all of those iron measures that we looked at in that first question are very good measures. The serum iron itself is a good measure. The percent saturation is an excellent measure, as is the iron binding capacity. But all of those don't mirror the iron stores as well as ferritin does. Some hints that you may be looking at an iron deficient patient. Remember that they are microcytic and hyperchromic. Remember that almost always you'll see an elevated RDW. This is one of the anemias that usually has a decrease in the reticulocyte count. You don't have enough iron, so the marrow actually can't make red cells, so the reticulocyte count is low. And often you will see a reactive thrombocytosis, which is also a nice clue. So an elevated platelet count or secondary thrombocytosis. Here's a picture. Let's see if I can make this work here. All right. Can y'all see, is the arrow up there? I hope so. All right. If you'll look at that red cell I left the arrow on top of, it's not as easy as I thought. Smaller than it should be. There's really not a good marker on this slide to look at size, but that's a little small. Pretty pale. You know, a normal red cell should have a small area of decreased stainings like this one, but most of these cells have just a very thin rim of hemoglobin. Most of them are smaller. You can see this cell. This is a giant platelet. I'm sorry, do what? And these are all also numerous platelets throughout. So this is a smear from iron deficiency anemia. There are some things that you just have to learn, and you just have to learn the pattern of the test for iron deficiency and later on for anemia of chronic disease, because this is important. This is how you differentiate between the two, and this will be on the test. Iron levels in iron deficiency anemia should be low. Iron binding capacity, the ability to actually carry iron, should be high because there's not a lot of iron. The percent saturation of that capacity should be low because there's not much iron, and your ferritin should be low as well. So the classic pattern here is low saturation, low ferritin with a high iron binding capacity. How many of you know what the soluble transferrin receptor is? Show of hands. I don't have an audience response. Okay, so a few. This is not a very common test. It's been relatively recently put into clinical practice and is still not something that's used often, but it is a good discriminator when you sometimes have that difficulty telling the difference between iron deficiency anemia and anemia of chronic disease. The soluble transferrin receptor can help. And basically, it is an assay to look for unbound receptor. And it should be elevated. It measures the receptor on the red cell membrane, and those increase with a decrease in iron because they're trying to grab all the iron that's out there possible. So they go up with iron deficiency. So this is a good discriminating test sometimes between iron deficiency and anemia of chronic disease. Remember, if at all, ask what the gold standard is. Ferritin's a good marker, but the gold standard for knowing how much iron a patient has is always a bone marrow, okay? Absolutely always a bone marrow. So if asked the best test, the gold standard, you should answer marrow. Usually you can figure it out without getting to a marrow, though. How do you treat somebody with iron deficiency? Well, you need to figure out why they're iron deficient and try to fix that. And then you need to replace their iron. We use oral iron replacement when at all possible. Usually like to have somewhere around 200 milligrams of elemental iron a day to build up their stores. And remember, when you prescribe that iron, ferrous sulfate 325 is what we're all used to writing. That's about 65 milligrams of elemental iron per tablet. So that's why we usually give 3 a day. It's because that gets you close to 200. You can use IV or IM iron replacement if you have a patient that's intolerant to oral iron. IV and IM iron replacement does not fix you any faster, so there is no reason to use it unless you have a patient that is intolerant or absolutely non-compliant with oral iron. There are risks to IV and IM iron. The worst one, of course, is anaphylaxis, and it's not fun. So don't use it unless you have to, but if you have to, it works. Okay, change gears a little bit. This is a 44-year-old with rheumatoid arthritis and anemia. Her lab studies, she has a hemoglobin of 9, a reticulocyte count of 1, an MCV of 85, RDW of 12, an iron of 30, an iron binding capacity of 200, a percent saturation of 15%, and a ferritin of 400. Okay, so she's got a low hemoglobin. She's anemic. She's got a low reticulocyte count for that. She's normochromic with a normal RDW. Her iron is low. Her iron binding is low. Her saturation is a little on the low side, and ferritin is high. The cause for this anemia is most likely iron deficiency, aplastic anemia, anemia of chronic disease, or beta thalassemia. Oh. All right, go. Yay. You either all cheated and looked at the answer, or you're really smart. I'm going to assume that you're all really smart, you know everything, and I can go home, right? I like that. Okay, so who's going to teach this part? Well, you're all right, as you already know, anemia of chronic disease. Now, why was that an anemia of chronic disease?